Welcome everybody to the VASCERN Webinar on the Diagnostic and Management Pathway for Capillary Malformations with today's presenter, Dr. Eulalia BASELGA from Hospital Sant Joan de Déu, Barcelona, Spain. First, a few general instructions before we start. Next slide, please. So basically, just to let you all know, the webinar will be recorded and it will be available on our YouTube channel after the webinar. Any questions should be asked in the chat box, or if you prefer to ask the question out loud, you can just click on the raise hand button and then we can try and get to you. And finally, if you have any technical issues, please either inform me in the chat box or you can contact me via email and we'll try to help you. Next, please. So just briefly, for those of you who don't know us already, VASCERN is the European Reference Network on Rare Multisystemic Vascular Diseases. We're one of the 24 ERNs, and we currently gather 39 healthcare providers, full members, from plus 6 affiliated partners coming from 19 EU countries. As of January 1st, 2022, we added 13 new HCP full members, one of which is from Dr. BASELGA's hospital today. So we also include over 70 patient organizations from all across Europe who make up the European Patient Advocacy Group. VASCERN is organized into 6 rare disease working groups, which is also new as of January. We've had a 6th group that we've just created. So there's the HHT working group, which is the Hereditary Hemorrhagic Telangiectasia working group. The HTAD working group, which is the Heritable Thoracic Aortic Diseases, and they deal with diseases such as Marfan syndrome and Loeys-Dietz syndrome. There's the MSA working group, which is the medium-sized arteries working group, and they cover the disease of Vascular Ehlers-Danlos syndrome. There's also the PPL working group, which is the Pediatric and Primary Lymphedema. They cover a variety of diseases, disorders involving problems of the lymphatic system. The VASCA working group, which is the Vascular Anomalies working group of today, who covers over 40 rare diseases, all to do with vascular anomalies. And then the newest group that's just being created as of January is the Neurovascular working group, or Neurovasc, and presently they'll cover the CADASIL and Moyamoya disease. So all of these rare disease working groups, they also have input from the European Patient Advocacy Group in the form of a patient co-chair and deputy co-chair who attend all of the rare disease working group meetings. So all other information on VASCERN can be found, of course, on our website, vascern.eu. Next slide, please. And so for today's webinar, I have the pleasure to introduce Dr. Eulalia BASELGA from the Hospital Sant Joan de Déu. She's a pediatric dermatologist and head of the Department of Dermatology, and also coordinator of the Vascular Anomalies Clinic. And as I mentioned previously, the Sant Joan de Déu Hospital has joined us as of January 1st as a full HCP member. So I'll pass it on to you now, Dr. BASELGA. Thank you.
Hello, my name is Eulalia BASELGA, and I'm going to present the Diagnostic and Management Pathway for Capillary Malformations. Capillary malformation or birthmarks are pink to red stains that are present already at birth. And if we do a biopsy, that we seldom do a biopsy when evaluating this because we do a clinical diagnosis, but if we do a biopsy, what we are going to see is dilated capillaries and an increased number of capillaries in the dermis. So this is an Megalencephaly lesion or a malformation of the capillaries. Even if the histology is the same for all of these lesions, these are all capillary malformations, they all look very different from one to another. And the management of these patients is different. So it's very important to recognize what type of capillary malformation we're dealing with when we are evaluating children with capillary malformations. And this is what we are going to develop in this presentation, and that's why we have developed this algorithm for the diagnostic workup of capillary malformation. And the first things that we have to do is to recognize the clinical pattern. In this way, if we recognize that there are multiple oval to round slides, small lesions with a white peripheral halo, that this runs in family. Some of these lesions are already present at birth, but others appear later on. And as I said, this runs in families, so it's not uncommon to see a child and their mother, or the father and the grandmother and the grandfather with the same type of lesion. As you can see here again, these are very faint, pale, sometimes they look brownish, and they have this very characteristic white peripheral halo. Some of these children, they have a bigger stain in some part of their bodies. We call this the dominant stains. And some may also present telangiectasis or beer spot, that these are these white spots, usually on the extremities, that actually they represent telangiectasis, because when they are looked closely, in the center of the white spot there is a small telangiectasis. These children, they have capillary malformation or arteriovenous malformation syndrome. This is an autosomic dominant condition due to RASA1 mutation in most of the cases, and some of the cases to APH beta 4 mutations. And these children we have to consider when evaluating them to obtaining a baseline cranial and spinal MRI to check for AVM, because as 35% of these patients, they may have not only the capillary stains but an AVM malformation, as we see in the arm of this girl, as it's demonstrated by the arteriography. And the arteriovenous malformation that these children may present, they most often are in the periphery, but in as much as 10% of these 35%, the arteriovenous malformation are located in the CNS, either cranial or spinal. And it's very important to diagnose this before they give symptoms, because when they do give symptoms, this may result in a catastrophic hemorrhage or hemorrhagic stroke. That's why it's recommended to do a basal AVM. It is not clear how often do we have to repeat, or if these anomalies can be developed later on and not being present at birth, the arteriovenous abnormalities. If we see also these small, round, multiple, reddish capillary malformations in children with microcephaly, we have to think of this syndrome, microcephaly, capillary malformation syndrome. This is also a germline condition due to biallelic mutation on the STAMP gene. These children present with intractable epilepsy and seizures, and they need early referral to neurology. Actually, most of the times they're first seen by neurologists before even they refer them to dermatology to check for the stains. Another completely different pattern of capillary malformation is this one. This represents a reticulated capillary malformation, very purple, that sometimes goes with skin atrophy. And as you can see here in these two legs, sometimes there is hypertrophy of the extremity that is affected by cutis marmorata telangiectatica congenita. And this is in most of the cases the only abnormality that we can find. There is a long list of things that can be associated with cutis marmorata telangiectatica congenita, but actually in cases where the cutis marmorata telangiectatica congenita is localized, we don't commonly see any associated abnormalities. Only in cases with diffuse capillary malformation, sometimes they may be associated with Adams-Oliver syndrome, but this syndrome is really recognizable because these children, they have large defects on the scalp with cutis, with aplasia cutis, and also they have digital abnormalities and cardiac abnormalities. But for the regular cutis marmorata telangiectatica congenita, usually there is no need to do further examinations, and this is a stain that usually improves with age, and even the hypertrophy that may be apparent at birth, usually it's less apparent as the child grows. Sometimes we can see a vascular stain that it's warmer, that if we touch it or if we do thermoscopy, we are going to find that there is an increased temperature. These are stains that when pressed with a glass, they have a very rapid capillary refill. And as you can see here in the stain on the neck, they are kind of heterogeneous in color. It's not an homogeneous pink or an homogeneous red, but it have like a whitish and different an heterogeneity in color. When dealing with this type of vascular stains, we have to suspect an AVM malformation. And sometimes very early on, we cannot find a pulse or we cannot listen a breath, but we have to suspect that this can be a quiescent showing a stage 1 AVM malformation. In these cases, however, we will need a complementary exam. We will need a Doppler ultrasound that will demonstrate that there is a high flow to these lesions. And if we want to do something therapeutically, we have to do embolization or surgery. Usually we need to obtain either an MRI or a scan angiography to better delineate the architecture and the vessels of this AV malformation. Most of the time, the pattern that we can recognize is this one, the regular capillary malformations or regular purulent stains. These are well demarcated stains that vary in color from pink to red to purple. And in this case, when we recognize this pattern, the evaluation will depend many times on the location. On the face, we know that purulent stains on the face, if they are lateralized or sometimes bilateral, but maybe with a mild midline demarcation, these children, when the stain affects this portion of the face, the forehead, the portion that is gray in this diagram, these children are at risk of glaucoma and leptomeningeal angiomatosis that is called Sturge-Weber syndrome. So therefore, these children with a stain in the face that is lateralized to the forehead, they need an early referral to ophthalmology, and they should continue regular ophthalmologic checkups because even if they do not have glaucoma at the first visit, they may develop glaucoma even at later ages. And also we should refer them to neurology. And probably it's wise to obtain a cranial MRI at 1 or 2 years of age or at any time when they become symptomatic. Or if there is a change in symptoms, then we probably should obtain a repeated MRI. On the face, we can encounter a different type of capillary malformation. a very common birthmark that it's called salmon patch. And what's characteristic from this type of capillary malformation is the location, because salmon patches, they have a very repetitive locations. They are located in the glabella, where they have a V shape. They can affect the upper eyelids, sometimes the philtrum, and also perinasal area, and also they are present sometimes in the vertex, the occipitum, the nape of the neck, along the back, and also in the lumbosacral area. These are very common and very benign stains, and no further workup is needed for these children. Sometimes we may have difficulties. We may have a capillary stain that it's in a location that's characteristic for salmon patch, but it has a different configuration, like this one. It's not V-shaped. It can make we can have difficulties to know if this is a true porcine stain or if this is a salmon patch. So in these cases where we see capillary malformations in the glabella or the philtrum, that they are atypical, they are not V-shaped, they are darker or maybe wider, probably we should consider these children also at risk of Sturge-Weber and do the same workup that we mentioned before, to refer them to ophthalmology and to neurology and to obtain a basal MRI at 1 or 2 years of age. And the only exception where we have to do further workup when we see salmon patches is in this situation. If we see a salmon patch, children with salmon patch, but who is macrocephalic, then we have to consider another syndrome, especially if they have overgrowth. As we can see here in this picture, there is an overgrowth of the right arm in this child. Also look at the stain on the lower lip, which is also very characteristic of overgrowth syndrome. So this glabella salmon patch, philtrum salmon patch in a child who is macrocephalic, we have to think of MCAP, Megalencephaly, Capillary Malformation syndrome. This is an overgrowth syndrome due to PIK3CA mutation, and these children, they have an asymmetric overgrowth. They may have a reticulated capillary malformation that usually, when it's generalized, it has a sharp midline demarcation, as we see here in the thorax and the abdomen. And note also in this child the overgrowth of the right face. This child, of course, they also have intracranial abnormalities like megalencephaly. Some children, they may have polymicrogyria, ventriculomegaly, arnochalia abnormality, as we see in the MRI of this child. Capillary malformations on the lower lip, we have to think about another overgrowth syndrome that's named CLAPO. Look at how similar is from one patient to the other this capillary stain on the lower lip. It always have this central configuration, and then it goes into the lip with a V-shape configuration. These children, sometimes they only have this stain, but in many occasions they develop lymphatic malformation, and they may have an overgrowth, usually of the cephalic pole, but also elsewhere in the body, as we see in this young man that has macrocephaly. It has an overgrowth of the hand and also of the lower extremity. So when we recognize this lower leg capillary malformation, we have to check for lymphatic abnormalities, lymphedema, as this man had, and local overgrowth, and this is due to PIK3CA mutation. The lymphatic abnormalities and the overgrowth may be not really visible at birth. They may develop later on. So now if we move away from the face and we go to the trunk and extremities, one of the most important things is to check whether there is hypertrophy, as we see here. We see a thinner leg on the right in this girl, and this usually has not other associated abnormalities, a capillary malformation with hypertrophy. We have to check on the contrary if there is overgrowth, and then the workup it's going to be different, and we're going to go a little bit on this later. And also a second algorithm for overgrowth syndrome it's being developed. Or we may see a normal growth, and in this case, if we see a normal growth, this is just like a regular purine stain elsewhere, and mainly due to gene mutation. When we see overgrowth, then we have to pay attention to the quality of the stain. If we see a very faint stain like this one, very reticulated, faint, not very well demarcated, like here and also here, the workup is different than when we see a darker stain. In these situations of a reticulated capillary malformation with overgrowth, most of the time it may be an isolated phenomena. We may only see a proportionate soft tissue overgrowth, mainly leg discrepancy, and some they may have a true hemihypertrophy, especially those with very extensive capillary malformation. Many of these children with this reticulated capillary malformation and overgrowth, they have digital abnormalities like sandal gap, cutaneous syndactyly, macrodactyly, but usually they don't have any other health problems. And these children with reticulated capillary malformations and overgrowth, they may have mutations in PIK3CA, GNA11, the receptor of PIK3CA, and actually the term diffuse capillary malformation with overgrowth, or DCMO, has been coined to describe these patients that the only abnormality that they have apart from the capillary malformation is this overgrowth. However, this same type of stain, the reticulated capillary malformation, is also the same type of stain that we see in MCAP. Therefore, for children with a tentative diagnosis of the CMO, we always have to check if they are macrocephalic, because if they are macrocephalic, probably we are the child what has is macrocephaly, capillary malformation syndrome. Here you see again how the stain, the reticulated stain in MCAP, has a sharp midline demarcation, as I mentioned before. And look at how faint this capillary malformation and how reticulated. This frontal bossing is very characteristic also of the MCAP patients. On the other hand, if the stain is darker, very well demarcated, geographic, and even and especially if the stain it's not purely capillary, but they develop small vesicles over time like lymphatic vesicles, probably we're dealing with Klippel-Trenaunay syndrome, because these very geographic capillary lymphatic malformation are characteristic of this syndrome, which is defined by this geographic capillary lymphatic malformation, the overgrowth of the extremities, and also vein abnormalities. Many of these children, they have a lateral vein here, a dilated lateral marginal vein. It's an aberrant vein. And look at how come these varicosities develop over time. And this is very important to recognize because these children are at risk of deep vein thrombosis and pulmonary thromboembolism, which are the major causes of morbidity in these patients. We can also see these geographic well-demarcated stains in another syndrome. You see here the quality of the stain is the same one as we see in Klippel-Trenaunay. And this is another overgrowth syndrome, Cloves syndrome, that comes from congenital lipomatous overgrowth because they do have lipomas, with vascular because they have these capillary malformations, and also they develop AVM malformation. They may also have an epidermal nevus, and many of them they have scoliosis, skeletal and spinal abnormalities. These children are due to somatic mutation in PIK3CA. Sometimes we are not able to classify a patient under one name because the phenotype of the patient, it does not quite fit with any of these diagnoses. For these patients that do not fit for any well-recognized phenotypes, but we have a mutation in PIK3CA, we call them PROS, PIK3CA related overgrowth syndromes. Another overgrowth syndrome, and in this case is not related to PIK3CA but to AKT1, is Proteus syndrome. These are children that do not have most of the time overgrowth at birth. They look normal or may look normal at birth. These children, they may also have a capillary stain. You see here a faint capillary stain on the leg from this patient that has been published in the literature. And here the child started to develop an epidermal nevus that becomes more apparent with time. And also with time, that this is not present at birth, they develop this connective tissue nevus that it gives these cerebriform soles, which is very characteristic of Proteus syndrome. And look how over the years the growth started to be distorted and progressive, and this does not tend to stop. Here you see again the epidermal nevus. These children, they all have the same AKT variant. This is a very consistent variant in all patients with Proteus syndrome. Over time, the connective tissue nevus that gives this cerebriform aspect to the soles, it's more characteristic. And also with time, these children, they become a little bit lipodystrophic because they have many areas that they lack fat and then other areas that they are overgrowth. Proteus syndrome can be diagnosed clinically, and then we need confirmation also by the finding the variant in AKT1. And for the clinical diagnosis of Proteus, clinical diagnostic criteria have been developed. These children, is very characteristic that they have this cerebriform connective tissue nevus. As I said, they have a very asymmetric, disproportionate growth. It is not already visible at birth. They also have organ or visceral overgrowth. And one of the complications that over the years they develop bulla or cyst on the lungs. With time, they show this very dysregulated adipose tissue with lipomas, even in the myocardial septal lipoma. They may have a linear epidermal nevus like children with Cloves. They may have associated vascular malformations, not only capillary but also venous and lymphatic. They may develop specific tumors, which are meningioma, and in boys, very characteristic of this syndrome, testicular cystadenoma or genitourinary adenomas or parotid adenomas. They have a particular facial phenotype, and these children are at risk of deep vein thrombosis or pulmonary embolism. And also for the clinical diagnosis, there are some criteria that were present. They speak against the diagnosis of Proteus syndrome. That this is, if there is the overgrowth is already present at birth, this speaks against Proteus syndrome, as I said. And also, if they have this ballooning overgrowth, this speaks also against Proteus syndrome. So, in summary, when we see a capillary malformation on the trunk of extremities, the first step is to see if there is hypertrophy, overgrowth, or normal growth. It is hypertrophy, probably there's not going to be anything associated as a capillary malformation with hypertrophy. If the growth is normal, probably we're dealing with a regular capillary malformation or purine stain that most of the time is due to somatic mutations in GNAC. But if there is overgrowth, then there are several possibilities that we have to consider. If they have nothing much but digital abnormalities, probably we are dealing with what has been called diffuse capillary malformation with overgrowth, which can be due to PUC3CA, but also to GNA11, GNAC, and also actually the receptor of PUC3CA. If there is macrocephaly and the stain is reticulated, and especially with a stop midline, we have to suspect an MCAP, also another PIK3CA mutation syndrome. If we see a geographic stain on the legs with hypertrophy and also with dilated veins, we have to think of Klippel-Trenaunay, which also it has been shown to be due to variants in PIK3CA. If we see digital abnormalities, scoliosis, lipomatosis, or vascular malformation or epidermal nevus, we have to think of Cloves, or maybe we cannot give the name of Cloves because only one of the characteristics is present, and then we call pros not otherwise specify, to mean that these are abnormalities that are due to variants in PIK3CA. Whereas if we recognize that the growth is very distortive, it appears after birth, and over time they develop a cerebriform connective tissue nevus, we have to think in a Proteus syndrome due to AKT1 mutation. And here's the management and treatment. We have already covered some of these things during my talk, but I'm going to again insist on what if we in children with capillary malformation, arteriovenous malformation, probably we have to do a Doppler ultrasound of any skin lesions that is larger and warm to palpation, or and obtaining probably at some point an MRI. Cranial or spinal, and especially to repeat at puberty, and of course germline genetic testing. Treatment of the capillary stains in capillary malformation, arteriovenous malformations with laser is controversial. There are not large studies where they have treated these lesions with laser, so we don't know if this is completely sure. If we diagnose our child with Sturge-Weber syndrome, they have to be referred to ophthalmologists for regular intervals, and also have an annual neurology and repeat MRI if symptomatic. And then also we have to consider treatment of the facial capillary malformation, which can be very distortive and actually can affect the quality of life of these children. And also we may consider to start acetylsalicylic acid, which has shown to improve the number and the quality of the stroke-like episodes that these children may have. Antiepileptic drugs may be considered if we see on the MRI that there's a very extensive leptomeningeal angiomatosis. And today, actually, there are some case reports where they have used rapamycin prophylactically in children with very extensive leptomeningeal angiomatosis. If we see a facial capillary malformation that it's not on the forehead and so we don't recognize as being part of Sturge-Weber syndrome, in this location in the face, it's very important also to offer at least the possibility of doing laser treatment. If we recognize CLAPO syndrome, we have to check periodically for lymphatic anomalies and overgrowth, and we may consider also laser treatment of the capillary stain on the lower lip. And then if we recognize the phenotype, but usually are the neurologists or pediatricians who already recognize the microcephaly in children with microcephaly capillary malformation syndrome, and this they need mainly neurological follow-up. And now a few words about laser treatment of facial port wine stain. When is the best time to start? Actually, laser treatment can be done at any age. It does not need to be done when the child is little, but for all of us who do laser, we are completely convinced that early treatment is easier and that we can obtain better results. And this makes a lot of sense for many reasons. The skin of the baby is thinner, therefore the laser, who has a limited penetration, that is due to its wavelength, they can have better penetration in the thinner skin in babies. With time, the dilated capillary vessels on the dermis, they become more dilated. Also, usually young children, they have less melanin competing with the laser. As you know, melanin is a competitor of hemoglobin for laser absorption. Also, a practical consideration is that as child grows, the stain becomes bigger, so they need more shots when they are treated as adults. We also know that capillary stains tend to thicken with time, and then when they are thick, then it's very difficult that they respond to laser treatment. And another advantage, especially if we do laser in the very young ones, this can be quite well tolerated, much better sometimes than doing an anesthesia, general anesthesia. I actually treat a lot of patients, very young ones, without anesthesia. We have to make real expectation to the parents, because almost never we accomplish 100% clearance of the stain. In most of the cases, we can see an 80% of fainting, so there is an improvement. But this is something that needs many treatments. And we're talking about 10 to 15 treatments, laser treatments for. If we continue with the algorithm, for nevus simplex, we don't need to do anything. These are stains that usually fade away in the first year of life. But if they are persistent, because sometimes they do are, especially when they are very dark at the beginning, This can also be zapped by laser, especially so if we see a persistent salmon patch beyond 3 years, probably they need some laser to achieve the clearance. And then there's a lot of controversy with what's the significance of a salmon patch on the lower spine. And well, the consensus is that in children that this is the only thing that they have in this area, nothing has to be done. But if there is another sign of dysrhythm, maybe like a tail or a tag or an imperforated anus or a high fossetta, then these children should be scanned. If they are very young, this can be done with an ultrasound. But if they are more than 6 months, then we don't have the window to see it with the ultrasound, then an MRI is needed. For cutis marmorata telangiectatica congenita, not much has to be done. Nothing has to be investigated unless it's clinically evident. And usually we do not offer treatment as these fade a little bit or a lot with age. They do not completely disappear, but they fade a lot in color. And we can always offer laser later on, although the response of cutis marmorata telangiectatica congenita to laser is not excellent. And then for the overgrowth syndromes, if we only see an overgrowth and maybe digital abnormalities, but the child is not macrocephalic and nothing else is present, probably this should be also be seen by orthopedics. And it's important not only for investigation, but if treatment is needed, to do a genetic testing. For other well-recognized syndromes like MCAP, and also Klippel-Trenaunay, Cloves, and other PROS, there's going to be a specific pathway, patient pathway developed, and you probably would be available soon. I cannot reinforce how important it is to do the genetic testing in these children. And this has to be done in places where they have very sensitive techniques, because all of these syndromes, they represent somatic mutation. That means that only a few cells in the tissue can have the variant in the gene. So therefore we need very sensitive techniques like targeted NGS or droplet PCR to detect these variants. And to do the genetic testing, it's important not just for science or to better knowledge of the disease, but because depending on the genetic alteration, we can design a specific treatment for that mutation. For example, if we find a PIK3CA variant, we know that we can inhibit this activation of PIK3CA by alpelisib. Patients with Proteus syndrome, which have a mutation in AKT, may benefit from treatment with miracentab, although the development of miracentab is stopped right now, and there would be probably very soon a trial, at least in the NIH, for Proteus syndrome with miracentab. And then also, if we know that the mutation, for example, is in this pathway, we can always use, and actually we are using cropamycin for those children who need treatment. So the conclusions are that capillary malformations are clinically very heterogeneous, and that recognizing these shadows and shapes of the capillary malformation is the first step for categorization and workup. Location is essential to direct management, but it's more important that there are no two patients that are the same. Each patient has to be evaluated individually and by multiple specialists. So that's why it's so important that these complex patients they be seen in multidisciplinary vascular clinic. And genetic test, it is recommended that this is also only done in few laboratories to help management and also for targeted therapy.
Thank you, Dr. Baselga, for the presentation. That was really great and give a really good overview of the pathway for capillary malformations. Now, if anyone has any questions, please feel free to type them in the chat box and Dr. Baselga can answer those. There was one question already, which was asking when you talked about the child on slide 23 that had the Salmon patch, which wasn't a V shape. Do you have the name of the condition that that child had?
Well, it was a Sturge-Weber syndrome. Ah. So usually it's lateralized, but there's some instances where they can be centrally located.
Great. Okay. Thank you. That answers that. Any other questions? Leave a few minutes for people to think if they have anything they'd like to ask. This is the fourth patient pathway from the VASCA working group. So all of the patient pathways, the capillary malformation, venous malformation, severe infantile hemangioma, and lymphatic malformation, they can all be found on the VASCERN website. There's a comment saying nice presentation. So far, no questions. Perhaps it was very clear, everything you explained. There's someone said thank you. You can also mention while we're waiting to see if there are any questions that there'll be the next VASCERN webinar on February 24th, which will be from the HTAD working group on aortic surgery for what patients can expect before, during, and after surgery. So far, no questions. Oh, there's one. I may have missed it. In which scenario would you suggest to treat with sirolimus, everolimus?
Well, this is, as I said, this there is need of studies to demonstrate that this is useful. But actually, we have treated two children with very extensive bilateral involvement, leptomeningeal involvement with refractory epilepsy, and it helped them. We were able to stop one of the antiepileptic drugs and were well controlled after starting everolimus. I also know that our colleagues from Hospital La Paz in Madrid have treated a patient with very extensive leptomeningeal angiomatosis before the child had any seizures, and she was able to stay without seizures for 24 months. Then at 2 years, he started having seizures, but this is a very unusual long time for a bilateral involvement to have the first seizure at 24. So I really think that sirolimus helped her in this case. But Ann Kami, who's a neurologist from United States, I think that she has a clinical trial to demonstrate this.
Great, thank you. It's mostly just a comment saying thank you and great talk. Not too many questions. A good sign that everything you presented was very clear to everybody. Maybe I'll give just one more minute if there's any last minute questions. And the video, the recording, as well as the other 3 previous ones that have already taken place. As I mentioned, they'll be on the YouTube channel. So you can always take a look at them at a later date. So yeah, everybody was just saying thank you, learned a lot, thank you. Yeah. Okay, well, if there's no questions, maybe we'll end the webinar. And so a big thank you to Dr. VASELGA for your time and your expertise on this topic. It's very interesting and I think very beneficial to everybody who was connected. Wishing you all a very good night.
Thank you.
Thank you very much.
Thanks
everybody for connecting.
Okay.
Bye-bye.
Thank you. Bye-bye. Bye.